to Sriharsha. Thanks for the invitation and for the good evening, everyone. At the outset, I would like to thank Sriharsha and Sahasra Foundation. You are doing a tremendous job. This is not an easy task to do the regular on a regular basis. Since long time, since lockdown, I have been observing so many meetings. Kudos to you, boss. It is out of the thing. We can't do that. A sincere, heartful congratulations from our side. Okay. Hope today it will be a little bit a long lecture, but I'll be able. I'm trying to focus to give you the concepts in vertigo. See what happens whenever you say vertigo or whenever a vertiginous patient comes to your clinic. Suddenly, all of us, most of us, will get dejected ourselves. Just we'll give some beta histine or synergin and just we'll try to push the patient out. But what is making us or what is hindering us to make a diagnosis and to treat the patient? And second most common problem is we suppose that most of the vertigos are BPPV. It's not. What is making us to lag behind or to have a fear of vertigo? It's basically because of we are not having a conceptual strength in vertigo. But of late, in the last few years, in India, we have seen a tremendous development in the people who are working in the field of vertigo or neurotology, particularly. Thanks to all the giants of Indian neurotology. And I would like to particularly thank Dr. Srinivas Dursala sir and who has influenced me. Otherwise, being a surgeon, an aggressive otology surgeon and a skull base surgeon, slowly tuning the changes into the neurotology, particularly the vertigo. With this introduction, I would like to go to the next. I would like to dedicate and thank my teachers, Professor Jack Manyan, Dr. Srinivas Dursala, Professor David from John Hopkins Institute, and Professor M.V. Kirtane sir. So my concept of today's lecture, just before starting the lecture, Harsha. Hello?
Yes, sir.
In the middle, I'll be continuing the lecture. If I don't, unless I hear any response from you, I think that I am audible to you and I am visible to you. Okay, right.
Sir, you can go ahead.
Okay. So now, before going to get a clear concept, I have divided this topic into 5 subheads, and let's connect the dots at the end. So we are having a part 2 of this. Might be a few days later, according to the convenience of the schedule. So now, to understand vertigo, we need to understand 5 systems in detail. The first one is the vestibular system. Second one is the oculomotor system. Third one is the proprioceptive system or the skeletal system. Next is you need to have a detailed understanding of brainstem, cerebellum, cerebral cortex, and also the diencephalon. So in short, to be a neurotologist, you should be an ophthalmologist, you should be an ENT surgeon, you should be an orthopedic surgeon, right? And you should be a neurophysician. I hope most of the people, most of the target audience here are the postgraduates. And what is the first question I asked you? What is hindering us in making the diagnosis? Do we leave the vertigo cases? Why? Because we don't gain enough confidence in while speaking about the central pathology. We don't have enough confidence while speaking about other pathologies other than BPPV. Might be few years down the lane, A couple of years down the lane, most of us will overcome this thing and take it as a challenge. And I personally believe, let's shackle the barrier, intelligence barrier or intellectual barriers that is existing between us and the neurophysicians, so that we'll be on a equal frame with them in future. Right. So now let's go quickly into vestibular system, as most of the people are ENT surgeons here. I'll be little bit faster in this. So why? Because we regularly read it on daily basis. So regarding the vestibular system, these are the 4 things I am going to discuss here. Basic functional anatomy and physiology of the vestibular system, the vestibulo-ocular system, Eval's laws, and the Alexander's laws. So what is the function of the vestibular system? The function of the vestibular system is to maintain spatial orientation, to stabilize vision for the purpose of balance, especially during movement. So as we know, we have the vestibular end organs which sense the linear and angular acceleration, and they signal it to the brain. And the brain utilizes this information for stabilizing the gaze during the head motion, which is called by vestibulo-ocular reflex. Also modulates the muscle tone by vestibulospinal and the vestibulocholic reflex. So you know 5 end organs are there on each side. Organs are there on each side. The utricle and saccule will sense the linear acceleration, and the semicircular canals will sense the angular acceleration. So as we know, the labyrinthine fluid, we have perilymph and endolymph. For the posterior diet, the endolymph is rich in potassium. The perilymph is rich in sodium. And one more important thing to know is the blood supply to the inner ear. So the blood supply is primarily derived from the labyrinthine artery, which is a branch of anterior inferior cerebellar artery. So I will go to the next slide and come back again. This is much easier. So the 2 vertebral arteries will fuse to form the basilar artery, from which the antero-inferior cerebellar artery will form, from which the labyrinthine artery is a branch of ICA. This labyrinthine artery will divide into 2 branches. One is the common cochlear artery, and the other is the anterior vestibular artery. So this anterior vestibular artery supplies the utricle and the horizontal canal. Also, the superior canal and a part of the saccule. See, anywhere these 4 go together, because phylogenetically these 4 will develop together, and the other part of the inner ear will develop together. So the utricle, superior semicircular canal, the horizontal semicircular canal, and a part of the saccule supplied by the anterior vestibular artery. And the other part is the common cochlear artery, which again divides into posterior vestibular artery and the main cochlear artery. The main cochlear artery goes to cochlea, but the posterior vestibular artery will supply the inferior part of the saccule and also to the posterior canal. Harsha?
Yes, sir.
Sir? Me out finding this annotation. I can't see the annotation.
Sir, you can see, sir, up in the upper horizontal bar, right corner. You have an orange color bar. In that you can find the annotate.
Annotation. Pause, share, assign is there. Assign, control, mute, video, participants, chat. That's all is there.
This one option, sir. Options. A small 3 dots.
No. Okay, I'm unable to find it. The posterior vestibular artery usually it supplies the inferior part of the saccule and also the posterior canal. So now, we'll come back to this picture again. Now you see the labyrinthine artery, which is a branch of the ICA, which is being formed by the basilar artery. And as you all know, the basilar artery is formed by the fusion of the two vertebral arteries. This labyrinthine artery divides into anterior vestibular artery and the anterior vestibular artery and the common cochlear artery here. The anterior vestibular artery supplies the horizontal canal, the superior semicircular canal, the utricle, and a part of the saccule. Whereas this common cochlear artery divides into two parts. One will be the main cochlear artery, and another one is the posterior vestibular artery. The posterior vestibular artery supplies the saccule and the posterior semicircular canal. And also you can see there is supply from the external carotid artery system too. From the terminal artery, from the terminal part of the external carotid, one is the occipital artery, will give a meningeal branch. And also from the medial branch of the external carotid system, ascending pharyngeal artery is the medial branch of the ascending external carotid artery. From the ascending pharyngeal artery, you will have a posterior meningeal branch, which actually goes to the endolymphatic sac. Now, we have three semicircular canals, hence the angular rotation in three planes: yaw plane, pitch plane, and roll plane. So first we need to understand what are these planes. Actually, these planes are from the aerodynamics. The first one is like yaw plane. Yaw plane means it's an English yes, like very classical thing. Yaw means this moment, and the pitch means this moment. This is what we call it as pitch. Or the roll is something like keeping your ear to the shoulder. This is the roll movement. So yaw movement, pitch movement, and roll movement. So yaw means English no, or whatever you say. And pitch means usually I remember it. I used to remember this in this way because one of my friend, Mr. Kshitiz Malik, Dr. Kshitiz Malik from Delhi, has given me this tip while I was very early to this neurotology field. So what he says is like pitcher of beer, everyone will say yes. Pitcher of beer. And the third thing is the roll. And these are the planes what we do in rotation. But translation, you have three. These are for the utricle and the saccule. One is the heave. Heave means sideward movement like this. And bob means up and down. Up and down is called bob. Surge means fore up, that is forward and backward. So now we have learned 6 terms. One is yaw, pitch, roll for rotation, heave, bob, surge for translation. So the yaw plane, pitch plane, and roll plane, these occurs along one axis. Yaw means this one. It happens through the vertical axis. Through the vertical axis, it happens like this. Along this axis, the movement is there for the yaw movement. For the pitch movement, it's the Earth's horizontal axis. Along the Earth's horizontal axis, you are doing a pitch plane, pitch movement. And for the roll plane, just you do in this. And next one is you need to learn about the sense organ inside the semicircular canals and also the utricle and saccule. Now let's discuss about the macula of the utricle and saccule. As you know, there will be the hair cells over which will be the globular substance will be there, over which the calcium carbonate deposition, the autoconia will be there. And this here, one second, I'll again try. Now, what is the function of the utricle and saccular macula? This sends the verticality. The saccule sends the verticality. This is known as the plumber's bob. They use or the mason's bob actually. This is used to measure the verticality of any structure or a wall. This macula usually measures the Earth's vertical. It will correlate with the Earth's vertical. Now, the autocorrelate, and these are like aligned in, just will come in a few seconds, towards the center of the sensory epithelium that is called the striola. The orientation will be towards the striola. And when you come to the semicircular canal, the sensory epithelium or the sensory organ, end organ in that will be the crista ampullaris. So in the crista ampullaris, it will be present in the ampullary end of the semicircular canal, and it is connected from through and through, from one end to the other end. That means the crista ampullaris will act like a diaphragm. That means there is no communication of the utricular side of the ampullary end directly into the short arm of the semicircular canal. That means the vestibular, the crista ampullaris act like a diaphragm. Next, here we need to know one concept, what is called as cupullar time constant. What is this cupullar time constant? It is whenever you give a thrust to the head, or whenever you do a movement, hair cells will move, and the time taken for the cupula to return to 63% of its resting position of acceleration. Just before the acceleration, it is resting in one position. So once you have given an acceleration to that, it has moved up. And again, it is the time for the cupula to return back to 63% of its resting position, or 63% of the hair cells to come back to its position, normal position. This is called as the cupullar time constant, and it is 6 to 7 seconds. Why this is important? Why this is important is in per-rotational vertigo. That means whenever you rotate yourself, or whenever you do pradakshina, like you will be experiencing some sort of vertigo. The cupullar time constant is one thing, and of course the second thing is the velocity storage mechanism that will come later. Now, coming on to both the things, the vestibular receptor cells, the resting membrane potential is -40 to -60 millivolts, and usually even at rest also they will start firing. They are under continuous firing about 80 to 90 spikes per second. And one important feature is the responses are skewed to favor an excitatory over inhibitory response. That means the excitation gives more signal rather than the inhibition. Why does it happen? That I'll explain. Here you see, you could see my cursor, I hope. If the annotation I could not find out, extremely sorry for that. If you see here, the cupula from the crista ampullaris, the cupula is extending up and connecting the diaphragm, connecting the dome of the ampulla here. So that means this entire structure here is making like a diaphragm, thereby separate these two compartments of the ampulla. Here, this side in the first picture on the top left, this is the ampullary end of the semicircular canal. So the right side of this thing is leading to the semicircular canal, and the left side of this thing is leading to the utricle. Okay. This crista ampullaris along forms like a diaphragm, and this is separating. Whether in BPPV the autoconia used to come from the utricle directly like this and then go into the semicircular canal, but this never happens. Why? Because this is the cupula is acting like a diaphragm here. Now, as we all know, there are two types of hair cells, type 1 and type 2. And the most important thing is here you have to know that one biggest hair cell will be there, that is called as the On one biggest cilia on the hair cell will be there. That is the kinocilium. That is the master of the hair, master of the cilium there. And the small cilia, those are called as stereocilia. So these stereocilia are linked with the tip links. The tip is the thing that links between the two stereocilia, and all these are finally attached to the kinocilium, so that the entire thing will move like this. Any movement towards the kinocilium will give a positive response or a depolarization of the hair cell, and any movement towards the stereocilium will give rise to a negative response or hyperpolarization. Okay. Now, earlier I told one point: excitatory responses are more skewed rather than, or more favored rather than inhibitory response. Why does it happen? Just I will take a small example here. Just you can see suppose this is a hair cell. Can you see? This is a hair cell, and this is the kinocilium, and these are few stereocilia icon. Okay, this is just a notebook I am taking, and this entire thing is the hair cell, and this is the kinocilium, and these are the stereocilia. So now, if at all, if I want to excite, that means all the stereocilia are moving towards the kinocilium. The kinocilium can go back, 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 go back. That means almost all you have an infinity chance to move. The excitation will have an infinity chance to move. Almost all it can make 180 degrees, right? But if at all, if it is an inhibitory response that is moving towards the stereocilia, the kinocilium will just done. Beyond this, it can't move. This kinocilium from here, this position up to here, it can go. That's all. It can't go. It can't move more than this. But for excitation, it can move, 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 move. Yes. So this almost all a 360-degree rotation can be happen. That means up to infinity. That's why we tell that excitatory responses are more favored than inhibitory responses. In the center picture, Harsha?
Hello? Yes, sir. Yes, sir.
Can you seriously help me out in annotation? Because without annotation, it will be very, very difficult in the next few slides. I could not find anything there.
1 minute, sir. Sir, can you see the on the topmost you have one bar, sharing bar? Can you see that where there are mute, video, recorder, participants?
Yes, I saw that.
Yeah, right of chat, there is that annotate option.
No. In my screen that it is ending like with chat only. Nothing else is there beyond that. I could not see anything. Participants and chat are the last thing. Yeah, no issues. Srinivas has shared me this thing. I will. Okay, I will share from that. I will write from that. No issues. Srinivas has given me this thing. Okay. Oh, what happened? I don't know what happened. So the stereocilia in the middle, you see it is at rest. It is at rest. It usually gives around 80 to 90 spikes per second. And to the left of the picture, you are able to see that the kinocilium is moving towards the stereocilium, thereby causing the hyperpolarization and a negative signal. This is inhibitory response. And to the right of the picture, the kinocilium, the stereocilia are moving towards the kinocilium, thereby opening up the channel and causing depolarization. And this is the activation of the hair cell. Now, at rest, both type 1 and type 2 hair cells will be giving the signal. We have 80 to 90 spikes per second. And the second picture or the middle picture, all the stereocilia are moving towards the kinocilium, thereby giving an excitatory response. And in the third and the lowermost picture, you're able to see the kinocilium moving towards the stereocilium, thereby giving an inhibitory response. Now you can see three things here: attract, stimulation, and inhibition. So same picture again here. Same picture. Now coming on to the utricular and saccular maculas, as I told you, in the middle of the structure, in the middle of the sensory epithelium, you have this triola. And one important thing is the kinociliums are directed towards the triola in utricle, whereas the kinociliums are oriented away from the triola in saccule. In the above picture, that is in the vertical thing, the sagittal thing in the saccule, you can see the direction of orientation of the kinocilium or the hair cell polarization. It is away from the saccule, and in the utricle, it is towards the saccule. And again, same picture in a different perspective. You can see the upper horizontal is the utricular macula, and the side stands for the saccular macula. And in the saccule, the orientation is away from triola, and in the utricle, it is towards the triola. Now, if you see in the first picture, in the part A, this is a normal resting sensorium here, utricular macula. Okay, you can see the hair cells, you can see the gelatin layer, and also you can see the autoconia, and in between is the striola. Now, once there is a tilt towards the left side, whatever we are seeing on the screen. So I'm giving the example, the tilt to the left side. Once you tilt to the left side, what happens? All the kinocilium that are to the right of the striola, this right side of the striola are activated. These hair cells are activated, and all the hair cells that are to the left of the striola are inhibited. Means here the kinocilium is going towards the stereocilium on the left side, whereas the stereocilium is coming onto the kinocilium on the right side of the striola. So next, so what does it function like? Whether you move to one side, like when you translate, when you give a translational movement or when you give a tilt movement, how does the brain differentiate that? Whether you have given a tilt movement or a translational movement? Only with utricular macula signal can it detect that you have translation? Absolutely no. Absolutely no. Why? Because it needs another signal that's stating that. Why? Because even in tilt or in translation, the same type of signal goes. In the above picture, it is the tilt towards the right shoulder of the patient, or it is a tilt towards the right shoulder of the patient. So that means the autoconia are falling towards the kinocilium, thereby giving a response. In the picture also, when the head is being translated to the left, again the autoconia, because of inertia of mass, they stay there, and again the kinocilium are excited, and the autoconia and stereocilia are bent towards the right. In above and below pictures, the same type of signal is being sent to the brain. So that's why the brain can't decide whether it is a tilt or translation. Then what happens? In translation, in a horizontal movement, the head being stable, the semicircular canals will not be excited. So what happens? But in case of tilt, if you tilt your head like this, then what happens? This is a roll movement. We have seen three types of movement: yaw, pitch, and roll. See, this is roll. This is roll movement. That means your semicircular canal is being stimulated. So the cerebellum, particularly the nodulus of the cerebellum, will take the signal from the semicircular canal because of this roll movement, and also the signal from the utricle because of the head tilt. Okay, so it will combine these two things together and make sure that, okay, now the tilt has happened. It is not translation, it is tilt. So the structure which decides this is the nodulus. And of course, it is not only the semicircular canal input, along with that, The velocity storage mechanism also comes into play here. So now, one last important thing before we leave this, you need to know the movement of the fluid within the semicircular canal. So now, the most important slide of this vestibular pathology, vestibular system is this slide. So one important thing is in the kinocilium in the lateral semicircular canals are towards utricle or towards the utricular side of the ampulla. If the ampulla is like this and this side is the utricular side and this side is the canal side, all the kinocilia will be directed towards the utricular side like this. And so any utriculofugal, that is the kinocilia or the serocilia are going and pressing over the kinocilia, making a utriculofugal movement that is excitatory for the horizontal semicircular canal. But whereas for the superior semicircular canal and the posterior semicircular canal, that is the vertical semicircular canal, the kinocilium will lie away from the utricle. This is the utricular side, this is the canal side. All the kinocilium will lie like this. So any movement that pushes the kinocilium towards the stereocilium, that is towards the utriculopetal, towards the utricular movement, inhibits the canal, whereas this movement in the vertical canals, in this movement of the kinocilia will excite the canal. So it will be completely reversed in cases of horizontal canal versus vertical canal. In horizontal canal, the kinocilium is towards the utricle and utriculopetal movement excites the horizontal canal, and utriculofugal, that is away from utricle, will inhibit the horizontal canal, whereas vertical canal, utriculofugal away from the utricle will excite the canal, vertical canals, and utriculopetal towards the utricle will inhibit the canal. This is regarding the semicircular canal. Now let's come to utricle and saccule. As I have told you earlier, in utricle, all the kinocilia are towards the striola, and in saccule they are away from the striola. So now here next point is we need to know about three laws of Eval's laws are. First one is the axis of nystagmus will be in the same plane of the canal that generated the nystagmus. If the horizontal canal is being stimulated, the nystagmus will be in the horizontal plane. If the vertical canal is being stimulated, the nystagmus will be in the vertical plane. So this is Eval's first law. And in the Eval's second law, it's regarding the horizontal canal, what we have told earlier. Utriculopetal, that means towards the utricle, the movement of the fluid in the horizontal semicircular canal towards the utricle, that is towards the ampulla, or you can say ampullopetal. It will be much better term rather than utriculopetal. Ampullopetal, that is the movement of the fluid towards the ampulla, will cause the excitation of the horizontal semicircular canal, and ampullofugal movement of the hair cells will cause the inhibition of the semicircular canal. This is the second law of Eval. Third law of Eval is regarding the vertical canal. Ampullofugal movement of the hair cells or the kinocilium causes excitation, and ampullopetal will cause the inhibition in cases of vertical canal. What the vestibular hair cells? The vestibular nerve endings start and they travel in the superior vestibular nerve and the inferior vestibular nerve. We know that, and they finally reach the brainstem. In the medulla oblongata, this entire nerve tract, the vestibular nerve, will directly go and reach to the vestibular nucleus. Apart from vestibular nucleus, few vestibular nerve fibers will also directly reach to cerebellum. Okay, you need to know this point. The vestibular nerve fibers, they go and relay in the vestibular nucleus. Few fibers, even before relaying in the vestibular nucleus, few fibers go to the cerebellum. Where exactly they will go, we'll come to know the next few slides. So in the vestibular nucleus, for the sake of postgraduates, we know here there will be 4 vestibular nucleus. Every time it will be confusing. Okay, you know superior vestibular nucleus is there here. The medial vestibular nucleus is there here, the lateral vestibular nucleus, the descending vestibular nucleus, or the inferior vestibular nucleus. So there are the other names for these things. The superior is also called as Bechtel nucleus, the lateral is called as the Dieter's nucleus, the inferior is called as the spinal nucleus, and the medial is called as the Schwalbe's nucleus. So how can we answer? Because in postgraduate Viva examination or in theory Viva examination particularly, if they ask you what is Dieter's nucleus, suddenly like usually what our professor used to say during Viva, you have cerebral diarrhea will be there, but oral constipation will be there. So much of information is coming, but you can't spell out because of confusion. So what happens is, so for that to remember what I have myself, I have remembered this thing like this. BDS slim. BDS slim means Bechtel nucleus is superior nucleus. Dieter's nucleus is lateral nucleus. Okay, inferior nucleus is the spinal nucleus, and the medial nucleus is the Schwalbe's nucleus. BDS slim is the mnemonic I use myself. Even at any point of time, I can tell what nucleus is named after which person. Now, the most important concept to make it easy, you see the innervation of the or the fibers going into from which canal the fibers are going to which nucleus. The superior semicircular canal fibers predominantly reach the superior vestibular nucleus. The fibers from the horizontal semicircular canal and the posterior semicircular canal will predominantly reach the medial vestibular nucleus. That does not mean that they does not go into the inferior vestibular nucleus, they go, but I'm using the term predominantly. So from the superior semicircular canal, it is to the superior vestibular nucleus. From the horizontal and from the posterior semicircular canal, it is going to the medial vestibular nucleus. Why should we remember where these fibers are going and joining in the vestibular nucleus? This has a very, very clinical significance in vestibulo-ocular reflex. That we'll come to see. Now, this vestibular, after going to the vestibular nucleus, now we have completed the vestibular end organ, vestibular sensory epithelium, the vestibular nerve joining the vestibular nucleus. Now, how is this vestibular nucleus connected to other parts of the brain? Now, let's connect these dots. So, the vestibular nucleus is connected to the cerebellum. For what? For fine control of motor movements, or for the eye movement, fine control of the eye movement, or even the vestibulospinal. And the second thing is the communication of the vestibular nuclei with the spinal cord for posture control through the vestibulospinal tract. Either it can be medial vestibulospinal tract or a lateral vestibulospinal tract. Okay. And the vestibular nuclei are also connected to autonomic centers, the cardiovascular, visceral, and respiratory control. That's why in few patients of BPPV or vestibular neuritis, autonomic symptoms can be seen. So this connection will help you to know that autonomic symptoms can happen in cases of vestibular pathology. Next, the most important thing, the connection of the vestibular nuclei comes to the oculomotor nuclei. What is the role of this? To elicit the vestibulo-ocular reflex. Perhaps vestibulo-ocular reflex is one of the fastest reflex in the body. And vestibular nuclei is also connected to the cerebral cortex to get a spatial orientation, also to the limbic structures to get the spatial maps. So finally, the nuclei is connected to oculomotor nuclei to gain the vestibulo-ocular reflexes for the cerebellum, spinal cord, autonomic centers, and cerebral cortex. Now you have the 5 connections. So we will go in detail about cerebellum and the oculomotor nuclei in this lecture. The vestibulo-ocular reflex. What happens? What is the importance of vestibulo-ocular reflex? Whenever you turn the head to one side, but I want to focus my eyes on this screen in front of me, and I turn my head to right, but still the amount of rotation of the head is equated by the amount of movement of the eyes in the opposite direction. So if you move your head by 30 degrees, the eyes will move by 30 degrees in the opposite direction, thereby giving or staying the thing, the object of interest on the fovea. So why? How can we know that vestibulo-ocular reflex? Why should vestibulo-ocular reflex be developed? Why can't the eyes make? Why can't the eyes move? So just to have a small example, if you take a small piece of paper, something written on that, or a page of a textbook or something like that, just keep in front of you, and just move it. Move that. You can't read the line. You move it like two cycles per second. You can't read the cycle. You can't read the line. Why? Because the visual information will not allow your fovea to focus on that. Why? Because the visual information has to reach the cortex, the striate cortex, and from there it has to come back again to the motor area, that is oculomotor nuclei, and then come back. This is like the visual reflex is like a central party, like central parties are staying in Delhi and ruling the states. So everything they need to relate to the high command. The high command is the cortex there. So any information here from the eyes has to go to the striate cortex, then come back to the motor component, and then the end organ is the muzzle. So it takes a long thing. So for that, this much time will not be allowed to focus your fovea on one point if you move the paper. But in the same thing, if you move your head like this, keep the paper stable, despite of that, you can read that. Despite the moving of your head, you can read the paper in front of you. Why this? This is because of the vestibulo-ocular reflex. So this vestibulo-ocular reflex does not have a high command. Vestibular sense organ, it comes directly to the vestibular nucleus to the oculomotor nucleus, and directly to the end organ. There is no involvement of the cerebral cortex here. That's why it is so fast, right? So you have two types of vestibulo-ocular reflex. One will be the canal vestibulo-ocular reflex. The other is the otolith vestibulo-ocular reflex. So the canal vestibulo-ocular reflex, let's take an example of horizontal canal vestibulo-ocular reflex. So as we have seen, from the horizontal canal, the predominantly it will be to the medial vestibular nucleus. I told you earlier. From the superior semicircular canal, it will be towards the superior vestibular nucleus. So from the medial vestibular nucleus, what happens? Fiber cross the midline and go to the opposite abducent nerve. Abducent nerve is located in the pons. The vestibular nucleus is located in the medulla. So in the pons. From the abducent nucleus, the sixth nerve is stimulated, thereby the left-sided lateral rectus is being stimulated. And from the left abducent nucleus, the abducent interneurons cross to the opposite side and ascend in the medial longitudinal fasciculus and go to the right-sided third nerve nucleus, oculomotor nucleus, thereby stimulating the right-sided medial rectus. That means whenever you move the head to the left, right, my eyes will move towards the left. That means the left lateral rectus and the right medial rectus are stimulated. And this comes the most important effect. One slide from this entire presentation, I would say this is the slide to take home from the presentation. You need to know the projections from each of the canals. So we have discussed now, just now only we have discussed about the lateral semicircular canal to the medial vestibular nucleus. From the medial vestibular nucleus, the fibers go to the opposite side abducent nucleus, and from there to the opposite side lateral rectus, and again they cross the midline to the same side and come up the medial longitudinal fasciculus to the third nerve nucleus. Meanwhile, you also have another tract from the same side, from the medial vestibular nucleus to the oculomotor nucleus on the same side. This tract is called as ATD. In the mid picture I'm speaking. I'm sorry that I could not have this annotation tool so that I can mark here, but please bear with me. In the middle picture, you can see ATD. This is the ascending tract of Dieter. From the medial vestibular nucleus, it is going to the same-sided oculomotor nucleus. See here, these are the globes. This is the third nerve nucleus. This is the fourth nerve nucleus. This is the sixth nerve nucleus. And you remember one point: all excitatory connection, all excitatory signals will cross to the opposite side. All excitatory connections will cross to the opposite side. It will not go on same side except ascending tract of Dieter's. This is one exception, one golden rule you need to remember here. All excitatory connections will cross to the opposite side. Now you see here, from the lateral canal, it is going to the opposite sixth nerve nucleus. From the posterior canal, it is going to the opposite fourth nerve nucleus. From the superior canal, it is going to the opposite side, third nerve nucleus. All excitatory connections will cross to the opposite side, whereas inhibitory connections will be on the same side. One exception for the excitatory canal, excitatory connection that is going on the same side is the ascending tract of Dieter's. Now, for the from the horizontal canal, the excitatory signal is being traveling up in two pathways. One is to the opposite vestibular nucleus and to the opposite abducent nucleus. From the abducent nucleus through the medial longitudinal fasciculus and also through the ascending tract of Dieter's. So here you have two connections, right? But for the posterior canal, from the posterior canal, again the fibers predominantly relay in the medial vestibular nucleus. From there, it goes to the fourth nerve nucleus and also to the third nerve nucleus along the medial longitudinal fasciculus. Again, medial longitudinal fasciculus is the common point that takes fibers from the medial vestibular nucleus to the opposite sided fourth and third nerve nucleus. We'll come to know this picture makes sense after knowing the ocular movement. And the first picture, the superior semicircular canal. The superior semicircular canal relays predominantly in the superior vestibular nucleus, and from there it ascends up in the contralateral medial longitudinal fasciculus to the third nerve nucleus. And also it ascends in another two pathways. One is the brachium conjunctivum or the superior cerebellar peduncle, and also through the ventral tegmental tract. The ventral tegmental tract is not being shown in this picture, but the superior canal projections are ascending up in three ways. One will be through medial longitudinal fasciculus, the other will be through the brachium conjunctivum, the other one will be through the ventral tegmental tract. So, if you notice one thing, the medial longitudinal fasciculus is the common thing in all posterior canal projections, for the horizontal canal projections, and for the semicircular, for the superior canal projections, the medial longitudinal fasciculus is the common thing, right? So, apart from medial longitudinal fasciculus, you have the ascending tract of Dieter's in lateral canal, and apart from MLF, you have brachium conjunctivum and ventral tegmental tract in case of superior semicircular canal. So posterior canal you have only one projection, lateral canal you have two projections, and superior canal you have three projections. Rule of 1, 2, 3. Posterior canal 1, lateral canal 2, horizontal canal 3. Next is the otolith vestibulo-ocular reflex. The utricular, this is not macular, sorry. Utricular otolith, as you know, it senses the linear acceleration, and the saccular otolith, it senses the gravitational pull. Now, this is the innervation of the utricular and saccular, but these are less well understood. So, just for presentation, I have kept this picture, but briefly, just we'll go. If the head is being translated to the left, right? If the head is being translated to the left, that means that I have moved my head like this. The translation is there. That means on the left side, hair cells in the lateral activated. On the right side, the hair cells on the medial part of the utricle are activated. From the left utricle, the lateral part of the left utricle, these go to the and relay in the vestibular nucleus, and from vestibular nucleus they go to the opposite side, sixth nerve nucleus. See, all the excitatory connections are crossing midline. This is one important thing. From there, of course, again from the sixth nerve, it goes to the lateral rectus on same side, and neuron cross to the opposite side and ascend in the medial longitudinal fasciculus and innervate the medial rectus. This is how once you translate your head to the left, there is a movement of the eyes towards the right side. That means the right lateral rectus and the left medial rectus are stimulated. And this is the tilt movement. if you tilt the head towards the right shoulder, if I'm tilting my head towards the right shoulder, what happens? The utricular on the left side, the lateral utricle is being activated, and on the right side, the medial utricle is activated. The same thing. From the vestibular nucleus, these go to the fourth nerve nucleus. The fibers go to the fourth nerve nucleus, and from there, it stimulates the superior oblique, and from the third nerve, it stimulates the inferior oblique, thereby giving a counter roll. That means if I tilt my head towards my right shoulder, my eyes will turn towards the left side. If I tilt my head towards the right side, the eyes will get tilted towards the right side. This action is brought about by the superior oblique. Superior oblique is the right eye, and inferior oblique in the left eye. So this is a summary of the above, the previous two slides. This picture is a summary of the two slides. So if at all the otolith weaver is at fault, what we get is a ocular tilt reaction. In ocular tilt reaction, it is because of the symmetrical utricular inputs from both the sides. So you have three things. One is the skew deviation will be there, and the eye on the turn on the side of the head will be turned to one side, and the eye on the side of the turn will be at the lower level. That means if my head is turned towards the right, my right eye will be at a lower level, and the left eye will be at the higher level. Left eye hypertropia will be there, and so you see the head tilt is there. There is a skew deviation, and there will be an ocular torsion. That means if there is a head tilt towards the right, the right eye will lie at a lower level, the left eye will lie at a higher level, and the eyes will tilt towards the right side. That is, the upper pole of the eye tilt towards the right side. It is pathological. In physiological cases, if you tilt your head to right, the eyes will roll towards the left side. This is called as ocular counter rolling. That ocular counter rolling is lost in cases of utricular lesion. And finally, Alexander's law. You know, the nystagmus of the peripheral vestibular disease depends upon the position of the eyeball in the orbit, in the center position or in the extreme position. So if you see in the direction of the fast component, the nystagmus will be accentuated, and if you see in the direction of the opposite, in the direction of the slow phase, the nystagmus will be decreasing in intensity. This is called as Alexander's law. Let's come to the second. I'll go quickly from here. Like this is the oculomotor unit, the eye. Why should the eyes move? Why should the eyes move? Because once you see the visual world, you have loads of information that is going into the brain. Your brain will be having a limited space, limited data space. Might be 5 GB, 10 GB, 20 GB, depending upon your intellectual level, right? So you are giving a loads of information to the brain. So to avoid that loads of information constantly going in, so that the eyes move, and particularly in lower animals or the afoveate animals, we human beings have the fovea, which pinpointly focus on a particular one point. If you want to focus on your thumb like this, just you can focus on your thumb because of your fovea. But whereas afoveate animals, like something like rabbit, if you take an example of lateral-eyed animals or afoveate animals like rabbit, there the fovea will not be there. The entire eye will be giving the entire view of the surroundings to avoid being caught to the predators. So they have chosen that path to be on the safe side, to get avoided from the predators. And we human beings, a little bit more developed, have got the fovea in the eye developed, so that we can focus on precision. The prerequisite for a clear vision. If you see, the image should be held steady in the retina. Retinal image motion less than 5 degrees per second can be detected. That is first thing. So on the retina, you have the fovea. Within the fovea, you have the macula. So the best spatial resolution occurs within 0.5 degrees from the foveal center, and 2 degrees away from the foveal center, the movement of the projection of the image 2 degrees away from the fovea center, there will be 50% reduction in the visual acuity. How can we know? Just if you place your thumb in front of you and focus it, and if you also place another finger, another thumb in front, but you are focusing on your right thumb, the left thumb is also seen, but not with that clarity, but the lines on my right nail are seen very perfectly because my right nail is being projected to the center of the fovea, whereas this left thumb is being projected towards the little bit periphery of the fovea. So now eye moves. Why does eye move? I have told you. Then how can the eye move? The eye movement systems are 6 in number. This can be classified into 2 types. The movements that hold the image of the target steady on retina. If you are seeing something, there will be few movements. Sorry, someone has texted that my video is not clear.
You can go ahead, sir.
Yeah. So, like the first thing is the movements that hold the image of the target steady on retina. So this thumb movement, this thumb, I should be able to see. I should be able to see when my head is stable, it is not moving. I am able to see my finger. So there are few eye movements that make the image steady on retina. First one is the visual fixation system. That means my eyes are being fixated on my thumb. My eyes are being fixated on my thumb. This is the visual fixation. This happens only when my head is being stable and not mobile. But when my head is mobile, like this, 2 other movement systems will come into play. That is the vestibular system and the optokinetic system. These 3 are the movements that hold the image of the target steady on retina. And there will be few movements that are made by the eye to direct the fovea on the object of interest. Suppose you are seeing a movie, you are watching a movie. 4 or 5 artists are there. First you focus on one artist. If you want to see the wristwatch of the another artist lying on the left side of the screen, immediately you fix your focus. This is what we call it as you need to direct your fovea onto the object of interest. That is being brought by 3 systems. One is the saccadic system, the pursuit system, and the vergence system. So these are the 6 movements of the eye that are to be learned. Fixation system, vestibular system, optokinetic system, the saccadic system, pursuit system, and the vergence system. And the eyes are separated apart by 2.5 centimeters, and the medial wall of the orbit is in line with parallel to the mid-sagittal plane. But whereas the lateral wall of the orbit makes an angle of 45 degrees with the mid-sagittal plane. With the mid-sagittal plane, it makes 45 degrees. This lateral wall makes 45 degrees with the mid-sagittal plane, and this lateral wall, right and left, make 45 degrees each. Together, when they join, they make 90 degrees. These angulations are very, very, very important. Why? Because the medial walls of the orbit are parallel, whereas the lateral walls of the orbit make an angle of 90 degrees with each other and 45 degrees with the mid-sagittal plane. And the optic nerve is exiting from the globe, and this optic nerve is making an angle of 22.5 degrees. 22.5 degrees from the mid-sagittal plane or the medial wall of the orbit. If you take this as straight line, this angle is 22.5 degrees. So now the eye moves in 3 axes. One is the x-axis, y-axis, and z-axis. As I told you earlier, this is the pitch. The pitch movement, what we are doing, will be around my Earth's horizontal plane or the y-axis. See, this is the movement along the y-axis. Okay, and this is the movement along the z-axis. This Earth's vertical plane, right? And the x-axis, it is the naso-occipital axis, like this, in this sign. This happens like intorsion and excitrotorsion, intorsion and excitrotorsion. X-axis or the naso-occipital axis, the y-axis or the horizontal axis, the z-axis or the vertical axis. So now the extraocular movements, there will be, there will be 6 muscles. One will be the medial rectus, the lateral rectus, the superior rectus, the inferior oblique and superior oblique. As you know, the nerve supply, superior oblique is being supplied by the trochlea and the lateral rectus is being supplied by the abducens. Rest of the other muscles, other 4 muscles are supplied by the oculomotor. So one interesting thing is the attachments of these muscles, the vertical group of muscles, the vertical recti or the oblique muscles, lie in line with the canal. This is one very, very interesting thing. And in the above picture, if you see the first part, this is the attachment of the superior rectus muscle. See this straight line passing through the center of the globe along the y-axis, and this is the x-axis. But the line of attachment of the superior rectus is making some angle here. See, this angle is 23 degrees here and 67 degrees with the x-axis, this axis. So this gives you the secondary and tertiary actions of the muscle. If it is inserted in this plane, directly in this plane, there will be only primary action, like that of your horizontal recti. It will be directly inserted like this, without any angulation. So there will be only horizontal abduction or adduction for the horizontal recti muscle. But for the vertical recti muscle, if the plane is like this, they are not attached in this plane. They are making a small angle like this. This small angular attachment to the globe gives you the differential axis of rotation depending upon the position of the globe, thereby giving rise to secondary and tertiary action. So here you need to know the Sherrington's law of reciprocal innervation. So that means in my right eye, if my right lateral rectus has to be is excited and the eye has to move to the right side, that means the right medial rectus has to be relaxed. So that means excitatory signal to agonist and inhibitory signal to the antagonist. That means equal amount of signal goes to my excitatory signal goes to my lateral rectus and inhibitory signal goes to the medial rectus, thereby giving rise to Sherrington's law of reciprocal innervation. So what are the reciprocal pairs in your eye? What are the medial rectus and the lateral rectus? Second is the oblique pair, the superior and inferior oblique. The third are the vertical recti, superior and the inferior recti. Next comes the Herring's law of equal innervation. So during conjugate eye movements, the yoked muscles receive equal innervation. The yoked muscle. This is during the conjugate eye movement. Both the eyes have to move together. During the conjugate eye movement, the yoked muscles receive equal innervation. So what are the yoked muscles? Yoked muscles means if you see this bullock cart, this bar over this and these two will act like a yoked pair. If you turn to one side, the opposite side also will react like that. So what are the yoked pairs that we have? That means if my eyes have to move conjugately towards the right side, that means my right lateral rectus and the left medial rectus, these form one yoked pair. Okay, and then my right superior oblique and my left inferior rectus, right superior oblique and left, or left superior oblique and right inferior rectus, vice versa. And next is the right superior rectus and left inferior oblique. Why this is? The lateral recti, the horizontal movement will be happening. For the superior oblique, the main action is the intorsion and depression. And the inferior rectus is also causes the depression of the eyeball. So these two act to depress the eyeball. The superior rectus elevates the eyeball and the inferior oblique elevates the eyeball, apart from extortion. So these acts like, why should you know the yoke pair? Knowing yoke pairs is very important because the supranuclear control is based on the function and not based on individual muscle. This is phylogenetically one important evolutionary point that is being followed. So we need to remember the yoke pairs. Now, I'm going to tell you some 4 or 5 golden rules of the eye movement. The first thing, the lateral canals will try to push the eye to the opposite side. The lateral canals will try to push the eye to the opposite side. Suppose if my right lateral canal is being stimulated, my eyes will be pushed towards the left side. Okay? And if my left lateral canal is being stimulated, my eyes are being pushed to the right side. So the lateral canals will try to push the eyes to the opposite side. When you have equal signal, when there is no stimulation, when my head is stable, equal signals are coming from opposite sides, they stay like. And suppose if my left vestibular weakness is there, my left vestibule at rest is not giving both the vestibules will be giving around 80 to 90 spikes per second. The right side is giving 80 to 90 spikes per second. Left side is also giving 80 to 90 spikes per second. The left-sided vestibular weakness is there. This side it is giving only 60 spikes per second. That means my right eye is pushing the eye towards the, my right ear is pushing the eyes towards the left side. Left side. But immediately the brain stem comes into action, bringing the eyes back. This is the first component. So this is the thing. So the right eye, the right ear is trying to push the eyes towards the left. If there is a left-sided weakness and there is a corrective component back, that is the first component of your nystagmus. Second rule, the vertical canals. Vertical canals act in a different way. One is the superior canals will try to pull the eyes up. Remember this thing, superior canals will try to pull the eyes up, whereas the inferior canal will try to pull the eyes down. I would like to call this posterior canal like inferior canal rather than posterior canal, because the superior canal will try to pull the eyes up, the inferior canal will try to pull the eyes down. Now this makes sense. The inferior canals or the posterior canals will try to pull the eye down and a corrective component will come up. This is the upbeat nystagmus, what you see in posterior canal stimulation. And if you take the superior canal stimulation, the superior canals, what they do, they take the eyes up on stimulation and a corrective component will give the eyes to down, thereby giving the downbeat nystagmus. So lateral canals will push the eyes, vertical canal pull the eyes. The superior canal will pull the eyes up, the inferior canal will pull the eyes down. Another important thing is the obliques act in adduction. The obliques are the elevators in adducted position. Recti are the recti is are the elevators in the abducted eye. That means whenever the eye is in the adducted position, suppose if you take my right eye, whenever in the adducted position, the oblique muscles are the elevators or depressors. That means my inferior oblique will be the elevator in the adducted eye position. For my right eye, I am speaking, when my right eye is towards my nasal side, my inferior oblique is my elevator and my superior oblique is my depressor. But when I am seeing towards my right shoulder, my right eye on the in the abducted position, the eye. So this is another rule. The obliques will act as elevators or depressors in adduction, and the recti will act as elevators or depressors in abducted eye. Next important thing, the superior group of muscles are the intorters. Superior group of muscles are intorters. Rectus or the superior oblique. Superior rectus or intorters. That means that they make rotate the upper pole of the eye to rotate towards the nose. This is intorsion. For my right eye, I am speaking. Left eye, this is the intorsion. This is intorsion movement. For the right eye, this is intorsion movement. And this is the extorsion movement. Extorsion means the upper pole will be rotated towards the shoulder. This is the extorsion movement. And the group of muscles, extorsions will happen usually with inferior people, or inferior people generally do extortion. That's how you can remember. So the superior muscles are intorters and inferior muscles are extorters. Now, if I ask you one question, name one muscle which will intort the eyeball and elevate the eyeball. If I ask you, name one muscle which will intort the eyeball, and elevate the eyeball. So intorter means either it should be superior oblique or superior rectus, right? And elevation is brought by superior rectus, because superior oblique will cause depression. Because of it was inserted onto the base, so that it causes depression. So if I ask you, name one muscle that cause extortion and depression. Extortion means these are caused by the inferior muscle, that is either inferior rectus or inferior oblique. But inferior oblique causes elevation and inferior rectus causes depression. So the answer is inferior rectus in the second question. Perfect. Now, one more important golden rule here. Remember this thing. Superior muscles will get innervation from the same-sided vertical canal. Remember this. Superior muscles will get innervation from the same-sided vertical canal. Now, if I stimulate my right posterior canal, you know what does the posterior canal do? I told you earlier, it will try to pull the eye down. So what are the muscles that try to bring the eye down? One will be the inferior rectus, the other will be the superior oblique. Simple. The posterior canal what are the muscles that brings the eyes down? One will be the inferior rectus, the other will be the superior oblique. So now, if my right-sided posterior canal is being stimulated, the eyes are brought down, okay, by inferior rectus and the superior oblique muscle. But which side the superior oblique is there, which side the inferior rectus is there? When my eyes are in primary position, that is very important. So when my right posterior canal is being stimulated, the eyes are brought down by the right-sided superior oblique muscle and the left-sided inferior rectus muscle. So when in VPPV or in theoretically, whenever you speak, you will have a lot of confusion. So simple. The superior muscle will be on the same side of the stimulation of the canal. My right-sided canal is stimulated, right-sided posterior canal is stimulated, right superior oblique brings the eye down, the left inferior rectus brings the left eye down. Done. My right superior canal is being, suppose left, let us take for the left side. Left superior canal is stimulated. What does the superior canal do? It takes the eyes up. It makes eyes, it pulls the eyes up. So what are the two muscles that takes the eyes up? One is the superior rectus, the other is the inferior oblique. So as I have stimulated my left superior semicircular canal, the eyes are being pulled up by superior rectus and the inferior oblique. So which sided superior rectus and which sided inferior oblique? My left-sided superior rectus and left-sided inferior oblique. This clears all your confusion in management of BPPV. Remember these four beautiful golden rules in eye movements. You'll never get confused. Next thing. One more interesting thing regarding the superior muscles. The superior muscles will be innervated by the corresponding nerve. The superior rectus is by the oculomotor nerve, and the superior oblique is by the trochlear nerve, as we know, right? And interestingly, the nucleus for these two nerves, particularly for the superior muscle, the superior rectus subnucleus of the oculomotor nucleus will be on the opposite side. That means my right superior rectus is being stimulated by the right oculomotor, perfect. But the fibers for the superior rectus muscle in the right oculomotor nerve are coming from the left-sided superior rectus subnuclei of the oculomotor nucleus. And regarding the trochlear also, the right-sided trochlear now, or the right-sided superior oblique, is innervated by right trochlear now, and the right trochlear now will have its nucleus on the left side at the level of the inferior colliculus in the midbrain. So immediately on the dorsal aspect, it crosses and comes out. We'll have that picture in the next few slides. So I told you 4 interesting or important things regarding the superior group of muscles. One is superior group of muscles are intorters. Second thing, superior group of muscles are intorters. The second thing is superior muscles, the same-sided vertical canal innervation will be there, and superior muscles, the nucleus will be on the opposite side. Now let's go quickly into the brainstem. So you know these are the cranial nerves emerging from the brain. So this is the olfactory, optic, 3, 4 coming from the at the level of the midbrain, at the level of superior colliculus and inferior colliculus respectively. 5, 6, 7 from at the level of the pons, and from 8 it will be at the level of the medulla. Might be few will be from the junctions. I'm not specific about that. Now, whenever you try to read the central control of vertigo or nystagmus, so many structures will come into play. You should be well versed with the structures. Harsha.
Yes, sir.
Hello? Yeah,
yes, sir.
Can I take another 15 to 20 minutes? 15 to 20 minutes is okay, or shall we conclude?
No, sir, you can take your time, sir.
Okay, then. Now, this is the cut section brainstem. See, the upper part is the midbrain, the mid part is the pons, and the lower part is the medulla. You have certain structures lying in this brainstem. So let's speak about the lower part first, that is the medulla oblongata. Here, one important structure, what you see is the inferior olivary nucleus. This velvet colored thing, light violet colored thing here is your medullary reticular formation with an asterisk over it. Here are the paramedian cell tract group. And you can see the vestibular nucleus lying in the annotation. Without annotation, it is very difficult. This vestibular nucleus is lying in the medulla oblongata, and also you can see the nucleus prepositus hypoglossae or the perihypoglossal nuclei complex. Again, this will be having 2 parts. Nucleus prepositus hypoglossae will be having 2 parts that we'll deal later. But this vestibular nucleus and the nucleus prepositus hypoglossae and the inferior olivary nucleus, these lie in the medulla oblongata. Next comes our pons. The important structures that lie in the pons are, one is the parapontine reticular formation, this pinkish structure, entire pinkish structure where you are able to see the 3 circles. This entire pinkish structure is a paramedian pontine reticular formation, and also we're able to see here the nucleus and the nucleus reticularis tegmentae pontis, NRTP. This is important in your pursuit eye movements. And this PPRF, paramedian pontine reticular formation, is very, very important for your saccadic eye movement, the center for the saccadic generator. So in the PPRF, you have 3 subnuclei. One is the nuclearis reticularis pontalis caudalis, nuclei reticularis pontalis caudalis. This is NRPC. The second is RIP, raphe interpostus nucleus, and parazygantocellaris dorsalis nucleus. These names appear to be a little difficult, but once you read them, it will be so easy. And coming on to the midbrain level, you have few important structures. One will be the 3rd nerve nucleus at the level of the superior colliculus, and the 4th nerve nucleus at the level of the inferior colliculus. And you have the rostral interstitial nucleus of the medial longitudinal fasciculus, and the interstitial nucleus of Cajal, nucleus of the posterior commissure, and one more important structure, the red nucleus. So these are the orientations of the structures in the midbrain. And if you see the medial longitudinal fasciculus here, the medial longitudinal fasciculus is traveling all the way. It travels up to the rostral interstitial nucleus of the medial longitudinal fasciculus, rostrally, and caudally up to the level of the spinal cord. It does not end in the medulla. It travels up to the spinal cord. This is the MRI section of the brain. Just you can see all the structures. This is the pons, the midbrain, the medulla, and this is the clivus, what we see. This is the pituitary here, the thalamus, and this is the corpus callosum, and this is the cerebellum here. Now, just I will go in detail about the midbrain, the pons, the medulla, and the cerebellum, and later we'll try to connect all the dots together. So if you take a cross section at the level of the midbrain, at the level of the midbrain, at the level of the superior colliculus, this is the structure what you see. Okay. The dorsal part is called as the tectum, where you have the superior colliculus. Sorry that I am unable to have this annotation tool, but hope you see my arrow at least. And see, the tectum is on the dorsal aspect. Here you have the superior colliculus, and the middle part is called as the tegmentum, and the ventral part is called as the crus cerebri. So at the level of the superior colliculus, you have the nucleus. The oculomotor nerve will emerge and will travel through the red nucleus substance and will emerge on the ventral aspect. Parasympathetic fibers will come through the Edinger-Westphal nucleus. Right. And also in the central mesencephalic reticular formation, you have the mesencephalic trigeminal nucleus is here. And the brownish structure, what you see here is the medial longitudinal fasciculus. And this dotted structure here is the red nucleus. And this horizontal structure lying with dotted thing is the substantia nigra, part of the basal ganglia. And in the crus cerebri, you have three types of fibers. The center one are the corticospinal fibers and corticobulbar fibers. And the medial most are the frontopontine fibers, and the lateral are the parieto-temporal pontine fibers. Parieto-temporopontine fibers. That means in the middle you have the pyramidal fibers, descending molar fibers. Now, now you see here, this is the aqueduct of Sylvius, and the A, what is mentioned A here, is the third nerve nucleus. From the third nerve nucleus, the nerve goes through the red nucleus and through the crus, particularly and exits from the ventral aspect, passes between the posterior cerebral artery and superior cerebral artery, and goes into the superior orbital fissure. We know that. Why did I keep this picture here? And the oculomotor nucleus, the inferior rectus nucleus, the inferior oblique nucleus is somewhere sandwiched between. We have one CCN, central caudal nucleus here. And as I have told you, superior rectus on one side, superior rectus muscle on right side, suppose for example, will be innervated by the right oculomotor nerve, but the fibers for the right superior rectus, superior rectus nucleus, the left oculomotor nucleus, they cross to the opposite side and go into the right oculomotor nerve, thereby innervating the right superior rectus muscle. So that's why isolated superior rectus palsy will not happen. Now, like you see the aqueduct of Sylvius, the third nerve nucleus, third nerve fascicle is going to the red nucleus and the cerebral peduncle. Now, there are three syndromes that are assigned at the level of the midbrain. One is the Weber syndrome, the other is the Benedict syndrome, the third is the Claude syndrome. Right? WBC syndromes are remember this way from the ventral to dorsal. W, sorry, I do not have this. I don't know. Annotation is not there. See, WBC from ventral to dorsal. You can remember this way. Ventral, the first syndrome is the Weber syndrome. Weber syndrome means involvement of the pyramidal fibers and the oculomotor nerve fascicle. So that means ipsilateral third nerve palsy with the contralateral hemiplegia, because these pyramidal fibers will go down and decussate at the level of medulla oblongata. The fibers which are on the left go down and cross at the level of the medulla oblongata to the right side, thereby innervating the motor component of the right half. So thereby you will be having the right-sided hemiplegia. That means involvement of left-sided superior collicus at the level of superior collicus, involvement on the ventral aspect here. Any ischemic injury will give rise to Weber syndrome. So now it's easy. Weber is third nerve ipsilateral, contralateral hemiplegia. Next comes your Benedict syndrome. Benedict syndrome is little dorsal to the in the middle area. You can see here this point. Involvement of the third nerve fascicle along with the red nerve nucleus. So there you will be having the tremor. The patient will be having the tremor, and also the third nerve will be involved. So that is the Benedict syndrome. The Claude syndrome is together. If the entire thing is being involved, this is called as Claude syndrome. That means the third nerve fascicle will be involved, the red nerve nucleus will be involved, and the corticospinal fibers, undecussated corticospinal fibers will be involved. So remember this thing: Weber's, Benedict's, and Claude syndrome for the level of the superior colliculus lesion. Next comes your trochlear nerve. The trochlear nerve is the only cranial nerve that emerges from the dorsal aspect. See, this is the aqueduct of Sylvius. The trochlear nerve nucleus is there. Immediately, it crosses to the opposite side and goes and innervates to the superior oblique. I told you, the superior oblique on one side will have the nucleus on the opposite side. The superior group of muscles will have that specialty. The nucleus will be on the opposite side. Right. This thing I will deal in the part 2, because the upward saccades and the downward saccade, that I will deal it in the second part. All these 4-5 pictures I will deal it in the second part. So now coming on to the Fontaine level. The midbrain is done. The Fontaine level at the level of the abducent nucleus. So see that this is the abducent nucleus, and one interesting thing, the facial nerve nucleus, the fascicle arises from the facial nerve nucleus. It makes a turn over the abducent nucleus and goes down. So sometimes in the facial nerve palsy, you can also see the nuclear palsy of the abducent. If this area is okay, so this abducent nerve fascicle will interspersed between the corticospinal tract, nerve fascicle will travel on the ventral aspect. Okay, so now you have three syndromes here. I remember syndrome is the sixth nerve fasciculus with the corticospinal tract. That means ipsilateral sixth nerve palsy with contralateral hemiplegia. That is the Raynaud syndrome. Raynaud syndrome. And the second is the Millard-Gubler syndrome. Millard-Gubler syndrome involves the entire thing. All these things are gone. involved. This is a Millard-Gubler syndrome and the Fowlis syndrome. The Fowlis syndrome means all the nucleus solitary is involved, the trigeminal tract nucleus is being involved, and the superior olivary nucleus is involved. The seventh nerve is involved, the sixth nerve is involved. Fifth nerve, sixth nerve, seventh nerve, and also the nucleus solitarius, which is a part of the 10th nerve, is also being involved. And also the superior olivary nucleus are involved. Now, one important thing regarding the abducens nucleus. You know, from the abducens nucleus, the abducens nerve and innervates the ipsilateral lateral rectus. But few interneurons are there. They cross to the opposite side, ascend up, and relay in the opposite side third nucleus. These interneurons from the abducens nucleus will ascend up and opposite side third nucleus, and from there gives rise innervates the medial rectus, thereby causing a conjugate movement to the same side. Suppose my right abducens nucleus is gone, so my innervation to the right lateral rectus is gone, and the innervation to the left, or the stimulation as a yoked pair to my medial rectus also will be gone on the left side. So next comes another important structure, the paramedian pontine reticular formation. As we have seen earlier, this paramedian pontine reticular formation will be having three important structures in that. One is the NR nucleus raphe interpositus and the nucleus parazygontocellulus, the PCD, right? So what is the importance of these structures? The NRPC will be having the saccadic burst generator. The saccade will be initiated and thereby stimulating the abducens nucleus. From the abducens nucleus, you know, the fibers go to the ipsilateral lateral rectus and to the contralateral MLF to the contralateral medial rectus. So a saccade generated here in the NRPC will be, the impulse will be sent to the ipsilateral sixth nerve nucleus, and also this impulse will be sent to the parazygontocellularis dorsalis. What does this PGD do? This PGD inhibits the opposite side sixth nerve nucleus. That means a saccadic signal is arrived at the NRPC. This stimulates the ipsilateral sixth nerve nucleus, and also this stimulates the same side PGD nucleus. In turn, this PGD nucleus will inhibit the opposite side sixth nucleus. So that means stimulation of one lateral rectus will give rise to relaxation of the medial rectus on the same side, and stimulation of the medial rectus on the opposite side will give relaxation of the lateral rectus on the opposite side. So this happens through PGD. But when does this saccade signal arrive at NRPC? The saccade signal will come from the RIP nucleus raphe interpositus, where you will be having the omnipause neurons. The omnipause neurons will be there in the RIP nucleus, which will be continuously they'll be giving the signal. But when a saccadic signal comes from the superior colliculus, this signaling of the omnipause neurons stop. So once these omnipause neurons stop giving the signal, the NRPC will be activated. Right? A signal from the superior colliculus comes to already stimulating omnipause neuron, thereby inhibiting its movement. Once the omnipause neurons stop giving the signal, the NRPC will be automatically taking it as a signal for the saccade generation and give a saccade generating signal to the ipsilateral sixth nerve nucleus and also to the PGD. And you see, from the sixth nerve nucleus, the lateral rectus fibers will go, and also from the interneurons, the fibers cross to the opposite side and ascend in the medial longitudinal fasciculus to the opposite third nerve nucleus. If the medial longitudinal fasciculus, you have a lesion. What do you call that? Lesions of the MLF? I'm waiting for the answer. Okay. Internuclear ophthalmoplegia. This is called as internuclear ophthalmoplegia. Right. That means the lateral rectus will be moving, but the medial rectus will not join that movement. The conjugate movement, the medial rectus will not travel, will join the journey little late, or the sluggish movement will be there, right? And one more important thing, if you observe from these two pictures, from all these three pictures, this abduction nucleus picture and here, the vergent signals will end directly at the third nerve nucleus without involving the medial longitudinal fasciculus. Horizontal VOR and the pursuit movement, the pursuit signals, they will end up on the vestibular nucleus, thereby traveling to the opposite side sixth nerve nucleus, which we know. Horizontal VOR and also the pursuit, right? And the horizontal saccades are generated in the PPRF, particularly NRPC. If you want to pinpointedly say, it is NRPC in PPRF. So, and all these fibers will be in the medial longitudinal fasciculus. So, if the medial longitudinal fasciculus is gone, the saccade also will be affected, the horizontal VOR will be affected, and the pursuit also will be affected. But only one movement that is not being affected is the vergence. Why? Because the vergence converge or relay directly to the third nerve nucleus, thereby skipping the MLF. Of course, few fibers will come through the MLF, but majority of the signal comes directly to the third nerve nucleus, skipping the MLF. So thereby vergence will be saved in most of the lesions. In any of the lesions, your VOR can be gone, your pursuit can be gone, your saccade can be gone, but most of the time the vergence will be intact, and even the vergence will reduce the type of nystagmus in case of lesions of the abducent or MLF or anywhere. So this is the tract of the MLF. Usually I used to think till very recently, like maybe 1 year back, till 1 year back, the medial longitudinal fasciculus starts in the medulla and ascends up. But no, medial longitudinal fasciculus, you have two variants. One is the ascending medial longitudinal fasciculus and the descending medial longitudinal fasciculus. The descending medial longitudinal fasciculus will go on relay in the sulcomarginal fasciculus, or just near the anterior horn cells in the spinal cord. Okay, and of course the ascending medial longitudinal fasciculus, you will have all the connections: the sixth nerve, the fourth nerve, the third nerve, and the higher end will be your cross-interstitial medial longitudinal fasciculus. No, sorry. Then comes your medulla. What is the important structure? What we have in medulla is the vestibular nucleus. Our vestibular nucleus lies in the medulla oblongata, and also along with the vestibular nucleus, you also have the NPH, nucleus prepositus hypoglossae. This nucleus prepositus hypoglossae, along with your medial vestibular nucleus, is the horizontal gauge center or the horizontal neural integrator center. So what are the important structures that lie in the medulla? That is, one is the vestibular nucleus, that is the medial vestibular nucleus, the inferior vestibular nucleus, and the medial longitudinal fasciculus, the nucleus prepositus hypoglossae, the inferior cerebellar peduncle, trigeminal nucleus, solitarius, ambiguous, and the inferior olivary nucleus. In cases of the lateral medullary syndrome or the Wallenberg syndrome, this entire area is being affected, thereby affecting the medial vestibular nucleus, giving rise to vertigo. The inferior cerebellar peduncle is being affected. This inferior cerebellar peduncle carries the fibers from the opposite side at the inferior olivary nucleus. From this inferior olivary nucleus, the fibers will go to the inferior cerebellar peduncle and reaches the cerebellum. Affected, the inferior vestibular nucleus is being affected, thereby giving again to vertigo. Nucleus ambiguous being affected, causing hiccups. Trigeminal nucleus is being affected. Tractus solitarius is being affected, and also affecting the corticospinal tract. Hemiplegia will be there. So this is the lateral medullary syndrome. This involves the vestibular nucleus. This is most important and need to be remembered. Comes the medial vestibular nucleus. That means medial medullary syndrome. Sorry, medial medullary syndrome. This affects the medial part of the medulla oblongata. That means your medial vestibular nucleus is being involved and nucleus depositus hypoglossae is being involved. That means the horizontal gaze center is being involved. The horizontal gaze is lost in case of medial medullary syndrome. Next comes another important part here, the inferior olivary nucleus in the middle. This forms a part of the Gulian-Mollaret triangle. This triad being the inferior olivary nucleus, the dentate nucleus in the cerebellum, and the red nucleus. That means from the inferior olivary nucleus, the fibers cross to the inferior opposite-sided inferior cerebellar peduncle and then reaches to the dentate nucleus, and from the dentate nucleus it reaches the red nucleus, and from the red nucleus they come down to the inferior olivary nucleus. This entire tract is called as the central tegmental tract. Central tegmental tract. So any lesion in the central tegmental tract or any lesion in this Gulian-Mollaret triangle will give rise to your oculopalatal tremor. Oculopalatal tremor. This also will deal in the second part, because see here, I told you the inferior cerebellum from the inferior olivary in the middle picture, in the midsection, at the level of the medulla, you have the inferior olivary nucleus. From the inferior olivary nucleus, the fibers cross to the opposite-sided inferior cerebellar peduncle, and from the inferior cerebellar peduncle, it reaches the dorsal vermis. From the dorsal vermis to the dentate nucleus and also the emboliform nucleus of the cerebellar nucleus. From the dentate nucleus and the emboliform nucleus, they travel through the superior cerebellar peduncle and reaches the red nucleus. Even though they don't get relayed, they travel through the red nucleus and come back to the inferior olivary nucleus. The inferior cerebellar peduncle connects the cerebellum to the medulla. The middle cerebellar peduncle connects the cerebellum to the pons, and the superior cerebellar peduncle connects the cerebellum to the midbrain. So see, the fibers through the superior cerebellar peduncle are going to the midbrain, and few fibers are getting relayed at the level of the red nucleus, and few are not relayed. These fibers coming down from the red nucleus to the inferior olivary nucleus are called as the central tegmental tract. The lesion in the central tegmental tract will give rise to your oculopalatal tremor. Right. Now the cerebellum. Know the cerebellum, the parts of the cerebellum, the vermis, the hemisphere, the nodulus, and also you have the flocculus and the paraflocculus. And you need to know the blood supply of the brainstem and the cerebellum. The two vertebral arteries fuse to form the basilar artery. From vertebral artery arises the pica. This is the territory of the pica, that is the postero-inferior cerebellar artery. It is engulfing the cerebellum from inferior aspect. The pica is coming from inferior aspect. So, and the antero-inferior cerebellar artery, it comes from the basilar artery. And if you remember, the labyrinthine artery is a branch of the ICA. So this inferior cerebellar artery hugs the cerebellum from the side, but on the lower aspect. And then comes the superior cerebellar artery. The superior cerebellar artery blesses the upside. So that means the superior cerebellar artery blesses the cerebellum. The antero-inferior cerebellar artery hugs the cerebellum from the sides, and the posterior-inferior cerebellar artery reaches the bottom of the cerebellum. So this connection, another important circuit to be remembered here for the generation of saccades. Okay. As I told you, from the inferior olivary nucleus on one side, the fibers cross to the opposite-sided inferior cerebellar peduncle and reaches the opposite-sided cerebellum, the dorsal vermis. Suppose if my left-sided inferior olivary nucleus, the fibers go to the right-sided inferior peduncle and reach the right-sided dorsal vermis of the cerebellum. And these fibers are inhibitory in action. That means inferior olivary nucleus will act like an inhibitor over the dorsal vermis, particularly the Purkinje cells in the dorsal vermis. Usually these Purkinje cells are inhibitory. So to stop that inhibition, you need another one to stop the inhibition of the Purkinje cells. So thereby the Purkinje cells will lose the inhibitory action. That means if the inferior olivary nucleus is being activated or stimulated, it will inhibit the dorsal vermis, thereby inhibiting the Purkinje cells, thereby releasing the inhibitory action of the Purkinje cells on the fastigial nucleus here. In the cerebellum, you have three nucleus. One is the fastigial nucleus, next is the nucleus intermedius, and the third is the dentate nucleus. The dentate nucleus is the lateralmost one. Here we have seen. See here, the dentate nucleus is the lateralmost one. The intermediate nucleus again will have two parts, emboliform nucleus and globose nucleus. The anterior one is the emboliform, the posterior one is the globose nucleus, and the medial one is the fastigial nucleus. So this fastigial nucleus is under the control of the Purkinje cells of the dorsal vermis, always under the inhibitory action. But once the Purkinje cell inhibitory action is gone, the fastigial nucleus will get activated. Where does this activity go? It goes to the opposite side through the superior cerebellar peduncle. These fibers from the fastigial nucleus go to the opposite side through the superior cerebellar peduncle and stimulate the opposite sided paramedian pontine reticular formation, thereby giving rise to saccade on the opposite side, or the gaze to the opposite side, or particularly saccade to the opposite side. That means stimulation of the inferior olivary nucleus on left side per se. Suppose, see, this is the left side. Stimulation of left-sided inferior olivary nucleus will inhibit the right-sided dorsal vermis, and also which loses the inhibitory action on the right fastigial nucleus. Thereby, right fastigial nucleus is being activated, thereby causing a saccade to the left. So that means stimulation of inferior olivary nucleus will cause a saccade to the left side. So same thing depicted in a color way, but this causes a confusion because the inferior olivary nucleus lies at the level of the medulla and this is the cerebellum. But you see, this crosses to the opposite side through the inferior cerebellar peduncle, and this have an inhibitory effect on the Purkinje cell. And few parts of the cerebellum having few functions. The fastigial nucleus is something related to the saccade. So if you go down, here, if my fastigial nucleus on right side is gone, so this fastigial nucleus is gone, okay, there is a stimulus for the saccade, but this fastigial nucleus is gone. So that means the signal to the left-sided PPRF is gone, but the signal to the right-sided PPRF comes from the left fastigial nucleus, that is intact. So the right-sided fastigial nucleus lesion will cause ipsi versus saccade. That means the left-sided fastigial nucleus will give a signal to the right-sided PPRF, thereby giving the saccade to the right side. That means a lesion in the right-sided fastigial nucleus, which is usually very rare. Isolated fastigial nucleus lesions are very rare. But theoretically, if you want to speak, if there is a lesion in the right-sided fastigial nucleus, the saccade on the left side will not be generated properly, but the saccade on the right side will be generated very well because of the left fastigial nucleus, which is intact, by giving ipsi versus saccade. So ipsi versus saccade, where do you see? In fastigial nucleus lesions and also in Wallenberg syndrome. What happens in Wallenberg syndrome? In Wallenberg syndrome, the inferior cerebellar peduncle is having the lesion. The inferior cerebellar peduncle on the right side is having the lesion, but the right-sided inferior cerebellar peduncle will be having the impact on the left-sided dorsal vermis. Thereby, the inhibitory action on the left-sided fastigial nucleus is gone. Thereby, the right-sided saccade is generated. That means right-sided inferior cerebellar peduncle lesion will cause a saccade to the right. So how do you remember? Ipsi versus saccade. That means the lesion is on the same side, the saccade is also onto the same side. So you will have it in cases of Wallenberg syndrome and also the fastigial nucleus lesion. Simply remember it as wife. Wife will be on the same side, right? Wife, W-I-F-E. W stands for Wallenberg, Ipsi versus saccade, and also in the fastigial nucleus lesion. So in the contra versus saccade, that is saccade to the opposite side, that happens in the lesions of the superior cerebellar peduncle. Fastigial nucleus is stimulated, but the fibers that are going through the superior cerebellar peduncle are at fault here. Thereby, the saccade is not being generated. Okay, thereby giving the contra versus saccade. So finally, we are connecting all the dots here. If you see, I am trying to connect the peripheral vestibular labyrinth, trying to connect the oculomotor unit, trying to connect the cerebellum, trying to connect the brainstem here. If you see, all the things are being connected in this picture. As I said, from the superior semicircular canal, you have a predominance of fiber inflow to the relay in the superior vestibular nucleus. From the superior vestibular nucleus, if you see, I told you there will be 3 upward inputs from the one upward input is through the medial longitudinal fasciculus. See, this medial longitudinal fasciculus to the opposite side, it's coming like this. It comes from the superior vestibular nucleus. And apart from medial longitudinal fasciculus, there will be other 2 inputs from the superior vestibular nucleus for the longitudinal fasciculus, the second is through the ventral tegmental tract, and the third one is through the brachium conjunctivum or the superior cerebellar peduncle. From the posterior semicircular canal, you have only one ascending input, that is through the medial longitudinal fasciculus. So that means the superior canal is having a dominance over the posterior semicircular canal. That's why you will have an upward bias rather than downward. But this partiality is being controlled by your cerebellum. So once you have a cerebellar lesion, again this partiality will come into play. Superior semicircular canal will be having the dominance over the inferior semicircular canal or the posterior semicircular canal. Thereby the eyes are being pulled up. Again, the brainstem corrector saccade will bring the eyes down, thereby causing the downbeating nystagmus. That means in cerebellar lesion, you are having the downbeat nystagmus because of the release of inhibition over the superior semicircular canal connection fiber. That's how you can simplify. And upbeat nystagmus. When does upbeat nystagmus happen? Upbeat nystagmus happen when there is a lesion in and around the medulla, causing the of the ventral tegmental tract to suffer. Thereby the medial longitudinal. Rohiwal sir, you want to repeat the thing? Hello?
Sir, in between we lost your audio, so can you repeat that?
Because this is the final output of the what we have learned today. This is now I am connecting the dots. Sorry, I told you we are connecting the dots. We have 5 dots here. One is the vestibule, the other is the oculomotor unit, the other is the brainstem, the other is the cerebellum. We are trying to connect all the 4 dots here. As I told you, from the superior semicircular canal, have a predominant relay in the superior vestibular nucleus. This we have learned. This ascends up in 3 different pathways. One is medial longitudinal fasciculus, the second is the ventral tegmental tract, and the third is the third one is the brachium conjunctivum. These are the 3 things. But predominantly for the superior semicircular canal is the ventral tegmental tract. Ventral tegmental tract is the predominant for the superior semicircular canal, even though MLF is there and also your brachium conjunctivum is there. And from the posterior semicircular canal, if you see, the relay is in the medial vestibular nucleus, and from medial vestibular nucleus to the oculomotor nuclei, it goes only through medial longitudinal fasciculus. Remember the rule of 1, 2, 3 I told. Posterior canal only one, that is medial longitudinal fasciculus. Horizontal canal 2 connections. One is medial longitudinal fasciculus and also the ascending tract of Dieter. Superior semicircular canal 3 connections. One is the medial longitudinal fasciculus, the brachium conjunctivum, and the ventral tegmental tract. Right. So if you see, the superior semicircular canal is having 3 connections to the oculomotor nuclei, and the posterior semicircular canal is having only 1 connection through MLF. That means there is clearly, naturally, a predominant effect of the superior semicircular canal over the oculomotor nuclei. That means there is an upward bias or a bias towards the superior semicircular canal, a partiality towards the superior semicircular canal. But there is a teacher to control that. The teacher is your cerebellum. Cerebellum controls. See, if you see from the superior semicircular canals, I told you in one point, from the vestibular nerve, all the fibers will go on relay into the vestibular nucleus, and also few fibers directly go to the cerebellum. I told you this point. These cerebellar fibers are particularly from the superior semicircular canal. They go to the flocculus, and from there again they are related to the superior vestibular nucleus. You see this circuit. From the superior semicircular canal, these fibers go to the flocculus, and then again they are being related to the superior vestibular nucleus. From superior vestibular nucleus, 3 tracts up: medial longitudinal fasciculus, the brachium conjunctivum, and the ventral tegmental tract. Now, this cerebellum is controlling the superior canal dominance throughout. But suppose if there is a lesion of the cerebellum at the level of the flocculus is gone, then what happens? The control of the cerebellum over the superior semicircular canal dominance is gone. The superior semicircular canals dominate. What does they do? They try to pull the eyes up. The eyes will be going up, and now the brainstem will come into action and brings the eye down, thereby causing downbeat nystagmus. This explains. Second thing, I told you the superior semicircular canal, predominant fibers go through ventral tegmental tract to the optic oculomotor nucleus. From the medial vestibular nucleus, it is through the ventral tegmental tract, predominantly through the ventral tegmental tract. Now, let's come to, if suppose there is the ventral tegmental tract, if there is a lesion in the medulla, caudal medulla, or in the dorsal or in the rostral medulla, anywhere in the tract of the ventral tegmental tract, that means the ventral tegmental tract is gone. But the posterior canal is trying to influence through medial longitudinal fasciculus, but the superior canal through medial longitudinal fasciculus are little weak. That means the posterior canal is dominating over the superior semicircular canal because of loss of fibers in the ventral tegmental tract because of a lesion in the medulla. Thereby, dominance for the posterior semicircular canal. What does the posterior semicircular canal do? They will pull the eyes down. They will pull the eyes down. So the brainstem will come into action again. It will give a corrective saccade. It will take the eyes up. This is what you say it as upbeat nystagmus. So downbeat nystagmus and upbeat nystagmus. This is very clear, and the entire thing lies in the cerebellum and the ventral tegmental tract. Before leaving, just I would like to conclude 2 more slides. You need to know the concept about the neural integrator. So what is a neural integrator? What is this picture? Anyone can tell? The youngsters might be very well familiar with this picture. DJ, disco jockey. What does he do? What does he do? He listens 2 or 3 tunes together and give a beautiful final output. What does he do? He receives the input from 3 or 4 songs, combine it in a very elegant way, giving a pleasant music. This is the function of the DJ. The same way, there is a neural integrator inside the brainstem particularly. For the horizontal movements, the neural integrator is the nucleus prepositus hypoglossi. And for the vertical eye movements, the neural integrator is the interstitial nucleus of Cajal. What is the significance of neural integrator is, whenever you turn the head, whenever you move the head, the semicircular canal will sense the angular acceleration at the place of sense itself, that is in the semicircular canal sensory epithelium itself. This angular acceleration is integrated to velocity signal, and this velocity signal is being relayed to the vestibular nerve, into the vestibular nucleus, and all the connections what we have discussed earlier. Now, for the vestibulo-ocular reflex to manifest, the eyes can't say that the eyes can't go with velocity signal. It needs a position signal. That means again the velocity signal has to be integrated into the position signal. This is our PUC physics. Acceleration integrated to velocity, velocity integrated to position. So that means the distance or the position in traveled in particular time is what you call it as velocity, and the velocity difference in particular time is known as acceleration. So that means the angular acceleration is being decoded into angular velocity by the semicircular canals, and that signal is being related to the medial vestibular nucleus. From the medial vestibular nucleus, the fibers go to the opposite sixth nerve nucleus. So from the sixth nerve nucleus, what happens? The sixth nerve will be receiving a velocity signal, a position signal also. So what happens? The sixth nerve nucleus is giving a signal to the eye that you go with 20 degrees per second. Up to where? So you need to have a position signal. So that position signal is being provided by your neural integrator. So that means if you see from the sixth nerve nucleus, the fibers go to the nucleus prepositus hypoglossi. The position signal is being generated, and these join the fibers that are leaving the sixth nerve nucleus. That means Now the final output from the sixth node nucleus is taking for the velocity signal as well as the position signal. The velocity signal given by the sixth node nucleus, and the position signal given by your hypoglossy. For the vertical eye movements, same thing happens with your interstitial nucleus of Cajal. Where is this interstitial nucleus of Cajal located? In the midbrain. So, for horizontal VOR, you have the nucleus tripogetus hypoglossy, and for vertical VOR, it is the interstitial nucleus of Cajal. So this is what we need to understand about this thing. And before we leave, just I wanted to tell you, I told you a concept of velocity storage earlier. Just a small demo video for that. This girl, actually, in our tradition also we have this thing, like what we say, South India particularly, with a long frock, kids used to play like this. And once they stop, still the frock will be moving. See that? The frock is still moving because the velocity is in vision, the velocity storage mechanism will be gone. So usually the nodulus and uvula will be having an inhibitory influence on velocity storage mechanism. That means if there is a movement, the velocity is stored. But once you stop the movement, the eyes have to stop. They should not rotate because the rotatory signal is already gone. The stimulus is gone. Who controls this? This is controlled by the nodulus and uvula. Okay. And if there is a nodular lesion, this inhibitory influence on the velocity storage mechanism is gone. That means velocity storage will be intact and the eyes will be rotating. And a simple test you can do it at your clinic is a tilt suppression test. How do you do this? You ask the patient to stand, close his eyes, ask him to rotate about himself, ask him to do pradakshina, ask him to do rotation, right? And once he rotates, after 10 rotations or 15 rotations, ask him to open the eyes, and immediately any one of us will be experiencing the rotatory vertigo, pararotational vertigo and post-rotatory vertigo will be experiencing. And once you open the eyes, or once you stop the rotation, and if you tilt the head, tilt your head down, that stimulates your nodulus. That's because of the spinocerebellar fiber, cervicus fiber there. And even this movement is what this movement called? Because of this movement, cerebellum nodulus will be activated. Thereby, the velocity storage is cut off. Thereby, the nystagmus will go off. In our tradition, if most of the people know, I fondly call this as a pradakshina sign, tilt suppression. Why? Because in our pujas also, after the completion of puja, we do pradakshina 3 times or 9 times. After doing pradakshina, immediately we are asked to bend your head down and pray to the god. This is what we do in our tradition. It causes the stimulation of your nodulus, thereby stopping your vertigo. This is clinically known as the tilt suppression test. So finally, take home message from the entire lecture, very long lecture, I know that it might be boring, but the concepts have to be very clear. So the thing is, take home message, the main function of the vestibular system you need to know to maintain clear vision, reflex and the ocular counter rolling. Second thing, the cupula occludes the ampullary end of semicircular canal. It forms like a diaphragm. It does not allow through and through connection. And third thing, the direction of the movement of the endolymph is the direction of the eyeball. And you need to know about the canal VOR, that is angular VOR, and the otolith VOR. And next is the orientation of the kinocilium in crista ampullaris and in macula. In horizontal canal, the kinocilium will be towards the utricle. In the vertical canal, the kinocilium will be towards the canal side. In the utricular macula, it will be towards the sclerola. In sacral macula, it will be opposite. Hello? And one, the golden rules. Hello, am I audible, Harsha?
Yes, yes,
Hello?
sir. Yeah.
You're audible. Yeah. And the last one, you need to remember the golden rules of extraocular muscles. I told at least the 4 points. The superior group of muscles are intorters. Inferior group of muscles are extorters. Superior group of muscles receive from the same side vertical canal. Superior group of muscles will be having the nucleus on the opposite side. So next is your brainstem circuits, what we have told, like in the midbrain at the level of superior collicus, inferior collicus, pons, medulla, and the cerebellum. Next are the cerebellar circuits. That is the connection of the inferior alveolar nucleus to the dorsal vermis, from the dorsal vermis to the inhibition of the Purkinje cells, and thus the losing the inhibition on the fastigial nucleus, thereby generating the saccade. Don't forget wife. Don't forget wife. Wife is Wallenberg syndrome and fastigial nucleus lesion will cause ipsi versus saccades. And then about the neural integrator and then the velocity storage. And that concludes the lecture. And there, if Harsha is okay with that, probably the part 2 will be there regarding the explaining each and every nystagmus in detail. So I hope this is not a boring lecture, even though it is a long, I know that, but I try to keep all the things and give you a very informative way, connecting all the dots. Thank you. And Harsha, thank you very much once again. And I thank the Sahasra and all the audience at this time. Like how many participants, so many participants are there? I don't know. Yes. Harsha? I am done, boss.
Sir, Pradeep sir.
Thanks.
Yes, boss.
Hello, Pradeep sir.
Hello? Yes, Harsha.
Sir, this is Dr.
Sir,
Sriharsha.
Sir, Srinivas, sir.
Sir, wonderful presentation. Wonderful
Thank you, sir.
presentation. 2 hours, 12 minutes and 46 seconds of recording going on. That is a full-length motion picture, but every minute was mesmerizing.
Sir, thank you, sir.
Wonderful, sir. Wonderful. This is super.
I need to connect all the dots, but there might be some lagging. I know that. But
and I think Harsha will make the recording available on his YouTube channel, because
Yes,
we
sir.
need to go through this again 2 to 3 times. Okay, sir. So
Yes,
it will
sir.
be super.
Available, sir.
Excellent. This was wonderful.
Now we would like to take question. Any audience can unmute and direct contact with sir. They have any questions?
yes,
Sir, if
yes,
possible,
sir. Yes, sir. Yes.
on Friday, sir, next Friday, if you're okay with it.
Yeah,
Sriharsha,
no issues.
Sriharsha,
Yes, sir.
can you make Rohiwal sir co-host? He has some comments to make.
Yeah, he can unmute, sir. Anyone can unmute.
I unmuted myself. Pradeep, what a wonderful session. What a wonderful session.
Thank you, sir.
Awesome.
Thank you.
So much of detailed neurology covered in such a nice, easiest way. I now realize why Srinivas Dorasala keeps on praising you every time.
Thank you, sir.
It's an awesome presentation. Very crystal clear concepts, and every time you have related them to the clinical conditions. My heartiest congratulations to you. Hats off. Hats off.
Thank you,
And
sir.
Sriharsha, thank you very much.
Thank you, sir. Dr. Vishal Pawar is also there. He's blessed. He's also blessed us with his presence. Where is Vishal Pawar?
Sir, before this thing, just before I want to say one word. Whatever I have learned in this 1 year of time is totally because of Srinivas sir. Because of Srinivas sir, all these things happened. Without him, Pradeep is not at all a neurotologist, just he's a surgeon, that's all. Thank you, sir, Srinivas sir.
Too humble.
Yes, sir.
He has generated interest in me too about vertigo.
Sir,
I was also a very aggressive mid-ear surgeon.
sir, that is there. But then, sir, I came to your place. You have one of the best, most well-equipped Vertigo centers. I was completely impressed. Nobody has dedicated so much of space only for Vertigo. Only you have done so much.
So nice of you for
So many
appreciating.
equipment. So many equipment. Almost everything is there. Yes, sir.
Yeah,
And I've seen with my personal eyes. Yes, sir.
And it's very, very kind of you for appreciating every time.
Good evening.
Thank you.
Yes, sir. Vishal,
good evening, Vishal.
Vishal, good evening. Vishal, sir, good evening.
Pradeep, sir, it was wonderful presentation. And I really liked the way you help us to remember things, like by telling the mnemonics, by telling the rules. And it was amazing, sir. It was really, I can say, like I was feeling like I am hearing Srinivas, sir.
Oh, thank you, sir. he's a master, like.
Yeah. Really,
it was. We are his student. I am his student. Yeah.
Yeah.
The
Even
neural integrator was a concept introduced by him during one of our balance con. Am I right?
Pardon, sir.
Neural integrator was a concept introduced to all of us during one of the balance con.
Yes, sir. In Mysore,
am I right, Dr.
I presented the same picture.
Like yes, Srinivas sir, but this comparison of neural integrator with Disco Jockey I have heard first time. That was really too good.
Even I am hearing for the first
time. Yeah. It was a very awesome thing.
I kept this picture in Mysore balance con also. I explained this neural integrator equating to DJ in Mysore balance con.
That's what I'm saying. During that balance con, first time I heard about this neural integrator.
Yeah, yes. Sir. And one more thing, last one he was telling about wife as this thing. I want to tell everybody he is still an eligible bachelor. Okay, he has gone deep into.
Oh, is it?
But he is an eligible bachelor. So this is a declaration for everybody.
That's why he can talk so boldly about wife.
Yes.
Yes, sir. Anything like?
Dr. Maloli, if he is studying so much, nobody will come forward to him.
No, sir. He studies at the same time. He has a leisure, good time, everything. So he's a multifaceted personality. Very good person. Very good by heart. Most important thing.
ENT, sir.
He specializes in the retrosigmoid approach for vestibular neurectomy.
Yes,
am I right?
Yeah, exactly.
Yeah. For vestibular neurotomy, and I also do this microvascular decompression for trigeminal neuralgia.
Yeah.
Decompression also. So that's what Srinivas sir turned me, like he's also evoked interest in me in Vertigo. So slowly I'm getting this thing into Vertigo field slowly. Thanks to Srinivas sir.
No, sir. But retrosigmoid is also very, very important, sir. Vertigo final cures we may find in the retrosigmoid approach.
Yes, sir. Yes, of course.
Yes, sir. Great. Sir, Maloli, sir, good evening.
Yes. Yes, I am listening all the while. No.
Sir, thank you, sir. Sriharsha, thank you again.
Sir, yes, thank you, sir. So, if sir agrees, we'll again meet again on next Friday, sir.
I'll be eager to see.
I have no issues. You need to be me. With me, I am ready anytime. No issues.
Yes. Yes, sir. So we'll plan on the 18th, sir. Once we'll check and we'll upload the video also and share the link with all the attendees who have joined in today.
Yeah, this is very essential to assimilate everything properly again. Huh?
Sir.
Thank you, Sriharsha.
Yes, thank you,
Thank you,
Pradeep, sir.
everyone.
Thank you, Srinivas, sir, and thank you all the audience who have patiently been with us.
Thank you, everyone.
And we'll see you again on December 18th. Sir, your final concluding marks.
No, thank you once again, Sriharsha and Sahasra ENT. And all the audience at this point of time, being 10 o'clock, almost like 2 hours, 15 minutes. Thank you, everyone. Nothing. Hope we'll catch you soon with the other part 2. That's a nystagmus very soon. Thank you.